Thanks everybody for coming along today. I'm going to talk to you a little bit about carbapenemase producing Enterobacteriaceae and understanding what has been declared as a public health emergency. So one of the first things I say about this CPE is making this point that people who have CPE have the same rights to access care and service as everybody else. That might seem obvious, but actually sometimes it tends to get a little bit lost, because in terms of infection prevention and control, there's often issues about single rooms and so on, facilities. And sometimes in the process of being preoccupied with that, we forget that the individual is at the center of it. So all infection prevention and control is based around patient care. And infection prevention and control can never be a reason to deny a patient access to service. The job of infection prevention and control is to make sure that patients get the service that they need with the risk being managed. Some context to this is that CPE is the latest wave in one wave after another of antimicrobial resistance, which has been really the substance of my working life in this area for almost 30 years now. The scale of the problem, I think, is reflected in the fact that in 2016, the Secretary General of the United Nations held a General Assembly meeting about antibiotic resistance. This is the fourth time in history that there's been a UN General Assembly meeting discussing a health issue. The last time was AIDS in the 80s. So that gives you some scale of how big a problem people think this is. And the WHO and the United Nations are saying that antibiotic resistance is the biggest threat to the sustainability of healthcare as we know it in the 21st century. And one of the points that I try to make also is that this is very much a story about people. It's not a technical issue primarily. It's not about genes, even though microbiologists like myself like genes and we like whole genome sequencing. This is actually about people. And it's not, people are losing out on a Christmas or a son's and a daughter's wedding, and that's already happening because they're getting infected with antibiotic resistant organisms and their lives are being shortened as a result of those infections. And again, it's not potential and it's not in the future. This is now. I mean, in my daily work as a practitioner, I'm dealing with patients who are getting infections with antibiotic resistant organisms whose chances of recovery are materially damaged by those infections. So it's not a future problem. And in the last, this year and last year, and for quite a while now, we've had the problem and it's getting worse. And CPE is the worst we've had yet, because all the antibiotic resistant bugs we've had in the past, and many of you will be familiar with MRSA and so on, we actually have we've quite a number of reserve agents we can use. For the worst of the CPEs, we have very, very little. And in the worst case was a case described so far, was a case in the US last year where they had no antibiotic at all for what 20 years ago would have been a common gut bug. And they had the woman died with a bloodstream infection that was untreatable with any available antibiotic. So one of the stories about how this matters to people is a man, and I'm not giving a great deal of detail here because to make sure that the patient can't be identified, but it's a man in his early 60s who has a very serious but now treatable condition. So 30 years ago, this man's condition was not treatable, but now it is treatable, but he needs a bone marrow transplant. That means during the period of the bone marrow transplant, he's going to be extremely vulnerable to infection, and vulnerable to infection with bugs that wouldn't bother you or I if we're in good health. This man now has CPE in his gut. He acquired that CPE almost certainly in a hospital during the course of some of the procedures he's already had. And if that bug gets into his gut during his bone marrow transplant, his chances of surviving are probably not better than 1 in 2. And that's the reality of what CPE means for patients already in this year, and it's going to mean more of that for more people next year. So do we have the antibiotics to get him through the transplant? The answer is we're not sure. If he gets a serious infection during the transplant, we will be struggling to manage it. So then in the 25th of September, the minister declared a public health emergency, and this was in the context of launching the Irish National Antimicrobial Resistance Plan. So we now have a national plan for dealing with antimicrobial resistance in the broad sense, and CPE is in that context. And then the next slide just reflects the chief medical officer's advice to the minister of the need to act on CPE and the need to declare it a public health emergency. Okay, so then what are the three letters about, the CPE letters? Well, if you're going to explain CPE to anyone, I always start with the last letter, which is the E, not the first letter. And the last letter stands for Enterobacteriaceae. So Enterobacteriaceae is a microbiological term that describes a very broad family of bugs that normally live in everybody's gut. So everybody around this table has got CPE, has got Enterobacteriaceae in their gut. You're supposed to have. Those gut bacteria that we all have sometimes escape from the gut. For example, one of the common infections is cystitis. So 1 in 3 women will get cystitis at least once in the course of their lifetime. That's almost always because one of these E. Enterobacteriaceae gut bugs has gotten out of their gut and into their bladder, and that's what's causing the infection. These gut bugs sometimes get into the gallbladder, they sometimes get into the blood, and when they do, they can cause infection. And that's a characteristic of all of these gut bugs. So E is for Enterobacteriaceae, harmless gut bugs in the gut. If they get out, they can cause you trouble. Okay, so now we're going to go to the C, and the C is for carbapenemase. So a carbapenemase is an enzyme that breaks down something called carbapenems. Carbapenems are a family of antibiotics, of which the best known one in Ireland is one called meropenem. So carbapenemase is an enzyme that breaks down this family of antibiotics. And then if we go to the next slide, we get a CPE is a gut bug that produces an enzyme that breaks down this family of antibiotics. So CPE is best read backwards. EPC is the gut bugs that produce this enzyme. Many people will be familiar with the term CRE, which is also widely used. Most of the time that people use CRE, they mean the same thing. There are some differences that can be important for an infection prevention and control practitioner, but for most people, most of the time, CPE and CRE mean more or less the same thing. So, why are the CPE able to destroy carbapenems? Well, the answer is that these are like a regular gut bug, except that they've downloaded an update. And the update that they've downloaded is a piece of code. It's genetic code, not computer code, but it is a piece of code that tells them how to make an enzyme that destroys carbapenems. And that piece of code is something that we call a plasmid. We go to the next slide, and these plasmids are very easily transferable. So all CPEs are not the same. There are different kinds of CPEs, so I sometimes like these as being like our sweets here and colour codes. And so OXA is the one that we have most of in Ireland. We also have KPC. KPC is the one that's been associated with the Midwest, so many people will know that there's been a problem with CPE in the Midwest for some time. That's mostly KPC, but most of the rest of the country is mostly OXA. There's another one in yellow called the NDM. That's not as common as the other two. The reason to mention it is because it's the worst one. And if you remember the 60-year-old man we talked about earlier, the one that he has is NDM, and that's the one for which we have the least antibiotics left. Okay, so I represent this as being like different bugs, but they're all carrying the same. Update of this, like this red Smartie here. So even though the bugs look different, they all carry the same update, and it's the update that's important. It's the update that makes it a CPE. So whichever one of the many different gut bugs you have, if that gut bug has got this update, it becomes a CPE. We go to the next one. And this has been difficult to some extent for people because, and for people across the board, understanding that this pandemic, so it's a global epidemic, because this isn't just Ireland. We have this OXA48 has spread all over the world. The KPC has spread all over the world. These are global problems of which Ireland is a part. And one of the things that's caused problems for people is recognizing this for what it is, because when we've had epidemics in the past, we expected to see the same bug in every person. So if you had an MRSA outbreak, then all of the people had the same bug, essentially. And that's not the case with this. In this case, the bugs may be different, but the update is common. And the other thing that makes this difficult for people is that mostly when we talk about an epidemic, like we have a seasonal epidemic of flu, we're looking at sick people. And with this, most of the people who get the CPE don't get sick, so that you can't see it happening so easily. So most of the patients don't ever get sick with CPE. And that is hard as well, because in the context of all the sort of pressures that an acute healthcare system in any country is dealing with, there's a tendency to say, well, if nobody is getting sick, why are we worrying about this? The problem is that if you wait until you've got a large number of people getting sick, the bug is already so widespread that you've lost the opportunity to control it. So the reason for trying to act early is that once it gets out of control, there's no way back. The other thing that's a problem is when people get sick with these CPE gut bugs, the nature of their illness is the same in every respect almost as the nature of the illness that they get with a regular gut bug. So if a gut bug gets into your bloodstream, you get very sick. You start to get shaking, you get a very high temperature, you become very unwell. You become very unwell whether it's a CPE or a regular gut bug, and the clinical illness looks the same. So you only know that it's a CPE if you've got good laboratory systems to identify it. But the reason it matters is that if you got a bloodstream infection with a regular gut bug, your chance of surviving are much better. And if you get bloodstream infection with a CPE, your chances of surviving are much worse. So there's a lot about CPE that makes it easy to ignore. It's easy to concentrate on other things and to think that this is a problem for another day, but all the time the problem is running. And the next slide is, so CPE is about poo. If you did this today, you probably got poo in your hands, and the question is, do you know how to take them off? And we have a very nice hand hygiene video that shows people how to take them off. And this is why we talk so much about hand hygiene. Is actually most people do not know how to wash their hands in a way that takes off the brown sticky stuff unless they've been specifically trained how to do it. And so you catch CPE by swallowing tiny traces of somebody else's feces. Feces is brown sticky stuff. It sticks to hands, it sticks to surfaces, it sticks to equipment. And CPE are very, very small. So it would take about 10 million CPE to make something the size of the head of a pin. So the fact that the tabletop in front of you looks clean doesn't mean that there aren't microscopic traces of feces on it. Actually, there probably are. Unless it's been very cleaned and decontaminated very recently, there probably are. So in a sense, it's part of human life, is that we swallow traces of other people's feces all the time, disgusting as it may seem. That's actually very much part of human life. Okay, but swallowing traces of somebody else's feces in hospital is much more dangerous, because in the hospital you've got people who are already very vulnerable. That's why they're in hospital. Lots of them are on antibiotics. About 1 in 3 patients in a hospital is on antibiotics on any given day. So the poo that you're swallowing is often from people who are already sick and on antibiotics. So the risk of this happening in hospital is much greater than the chances in other cases. Oftentimes, for members of the public, they think of, how could this be happening in a hospital? But in actual fact, a hospital is a perfect storm for the spread of antibiotic-resistant organisms. It's got all the elements there that make this easy to happen. And stopping the spread of antibiotic-resistant organisms in hospital takes a huge amount of effort and is really hard to do. And we do a lot of work on that in the HSE already. And what we're doing does work, but we have to get better at doing it more consistently and doing more thoroughly in order to break the chain of transmission more effectively. So how do we know if somebody's got CPE? Well, the lab has to find it. And the lab find it on 2 things. One is because somebody has an infection and somebody sends a swab to check what's causing the infection. That's what we call a diagnostic sample. But the other one, and most of the CPEs we find now, we find not in people who have any infection, but because they come into hospital, we're concerned they might have CPE, and we take a rectal swab or a stool sample from them just to see if CPE is in their gut. So that's what we mean by a screening sample. So why do we want to find out if somebody's got CPE when they come into hospital? Well, CPE comes out in poo whether you're sick or not. And if a person is carrying CPE in their gut, then they are a source of spread to other people, even though they themselves are not sick at the time. So carrying CPE means that it is a risk to me because it might make me sick later, but it's also a risk to other people because I might spread it to other people, and that's why we look for it so hard. The next slide. is just reflecting on this, that there is a very strong temptation, of course, not to look for CPE in a hospital system which is already under pressure on a lot of fronts. We have too many trolleys, long waiting lists, not enough single rooms and not enough staff, not enough money to do all the things we want to do, and now you're asking us to go looking. It's almost like you're asking people to go looking for trouble. And of course we are asking people to go looking for the trouble and to find the trouble while there's still time to fix it. What's happening in Ireland? Well, there were 282 people newly identified with CPE in 2016. It's over 400 in the first 11 months of this year, and so the numbers are going up month by month. But we've had 25 people in Ireland who've had bloodstream infection with CPE so far. The next slide, Audrey, is... So it's very much about this question of when is it too early to call the fire brigade. The strong temptation is to say, oh, well, it's only a small problem. But all the experience in other countries is that if you don't deal with it now, then it becomes a house fire and it's too late to call the fire brigade. And we can see that in the next slide. I think we'll show you what's happening in Europe. So here, purple means that every second bloodstream infection with Klebsiella, one of the gut bugs, is CPE, and that's where Greece is now. Italy is red. So 1 1/4, more than 1 1/4 of their infections with gut bugs, with this particular gut bug, is CPE. And you see Ireland is still green, but because we don't have that many. But this is the house fire. Greece and Italy are the house fire where you didn't call the fire brigade on time. Okay, so we've been down this road before in Ireland with antibiotic-resistant organisms, and this is a picture one of my colleagues did, which just goes to show you that we've antibiotic-resistant organisms that we've already lost control of. The horses have bolted. So we've got the MRSA horse and the VRE horse and the SPL horse. These are previous waves of antibiotic resistance that we didn't react to strongly enough, and we've now lost control of them and we'll never get it back. The CPE horse, we think, is about half out of the stable, so there may still be time to catch it. And when we fail, this is what happens, because for one of the other gut bugs called VRE, vancomycin-resistant enterococcus, you can see Ireland is already as red. We're as red as Greece on this. So this is what happens if we don't stop the spread. So fixing antibiotic resistance, Ireland's approach is outlined in the national plan. One Health is central to the idea, so it's about humans and animals and the environment. It's all together in this One Health idea. And basically there are two things we have to do, which sounds very simple, is using less antibiotics and getting better at stopping the resistant bacteria from spreading. Sounds very simple, but in practice it's actually really hard to do. So the summary is that CPE is a creeping pandemic. It's easy to ignore it unless you look very hard, and the temptation to ignore it is very strong. CPE and other antibiotic-resistant bugs is already shortening people's lives and costing misery, and it's costing the health service a lot of money already. It's part of that bigger problem of antimicrobial or antibiotic resistance. Fixing this means a root and branch change in how we run our healthcare system, a change in culture as well as everything else about how we do this. And the choice is pretty clear. We either act now and pay now while we can still control it, or if we don't act now, then what we do is we get it embedded and we pay for it forever because we continue to have infections. So this is a bit like, the next slide, Audrey, please. This is a bit like rhododendron in Killarney National Park. Rhododendron is an invasive species. It's now established in Ireland. We will never get rid of it, and CPE will follow the same path in all likelihood. So what can any one person do? Well, it does depend a bit on your role and where you are, but there are certain things we can all do. We can all try to use less antibiotics, and we can all try to help prevent bugs from spreading. Using less antibiotics, well, first and foremost, of course, if we keep well, then we get less infections, and then we need less antibiotics. If we have minor infections, undertheweather.ie is a really good website that gives people lots of information about how they can look after themselves. We need to spread the word about this creeping pandemic. We need to use and promote vaccines, because if there's less infection, there's less demand for antibiotics. And a really key thing, I think, for everybody who works in the health service in any capacity, and indeed for the wider public, is to try to change the way Ireland thinks about antibiotics. In Ireland, we tend to think about antibiotics as, oh sure, I'll have an antibiotic just in case. In other countries, in some other countries, the idea is recognizing that an antibiotic I don't need is a drug that might do me harm because it can cause side effects. Now, if I really need an antibiotic, then I have to accept there's some risk of side effects. But if I didn't need the antibiotic in the first place, I'm running the risk of skin rash, diarrhea and thrush, and I'm running those risks for nothing. So we need a really big mind change around how we think about antibiotics. Preventing bugs from spreading, first and foremost, is about hand hygiene, which is absolutely centerpiece of everything that we do in this whole business.